I want to thank all of you for coming today. One of you said, you just want to learn what the title means, three-legged stool. Well, let's get into that. If you have only two good legs on a stool, it's not stable. You need three. And for years, I thought I had two, but wasn't sure about the third one. I knew I had wound construction based on original work I did in 1990. Felt really confident about the Femtosecond laser, which we got in fall of 2011. But the lens was the tricky one. If you put in a monofocal lens, you had limited function. You didn't have any side effects. You put in a multifocal lens, you had very good function. It keeps getting better and better, but you had side effects. And we're never sure who was going to tolerate the side effects, which is halos, and who isn't. So also, you as a referring group, I never heard anybody say, please put money aside so you can go see Dr. Ernest for your multifocal lens. I just never heard that. But I am hearing about a lens I wish to talk to you about today. So here's the three legs: wound construction, femtosecond laser, and Vivity lens. Let's talk about wound construction. The purpose of any wound, I don't care where it is in the body, is to stabilize it mechanically until fibroblasts can seal it. In the eye, we have a secondary purpose. We have to avoid creating an undesirable refractive result, especially for premium lenses. The key factors that give a higher level of performance for cataract incisions are geometry and location. What you'll notice is missing from this is size. And I'll explain that to you later. What happened here? Oh, okay. So I started doing scientific studies in 1990 with a bunch of cadaver eyes. Then I started doing clinical evaluations, and the data was eventually published in journals. And to start with, I took a force gauge and a straight pin. I put the sharp part of the pin in the force gauge, and the blunt tip was used as a plunger. And I created a bunch of incisions, and I put pressure behind it. I also standardized the interocular pressure. And what I found was that all the square wounds could withstand up to 525 pounds per square inch, which is the highest the force gauge would go to. But any rectangular wound leaked. It was dependent on the interocular pressure. So the higher the interocular pressure, the more it could withstand. So how is this relevant to your patients? You can do anything you want after surgery. You can bend, you can lift, you can rub your eyes. No restraints on your activities, unless you're doing a toric lens. You don't want the lens to shift. So this was the first thing. Sam Basket came along years later and did a study showing that, let me just get this out of the way. Can you get this for me, please? This is blocking my up here. Sam Basket did a study and took square wounds and rectangular wounds, standardized interocular pressure, and measured the pressure 2 to 6 hours later, and found that there was a slow leakage in the rectangular wound, which is why you have higher incidence of endophthalmitis in these rectangular wounds. So then we went to a cat study, did this at Wills, with the help of Dr. Timperman and also Dr. Ralph Eagle, who's a pathologist. And what we did was we made clear corneal incisions and we made limbo incisions. And I purposely made rectangular incisions so I'm not having the square interfering with how well the location affects the integrity of the wound. If I did square, then it wouldn't tell me anything new. And if you take a look to the right, you'll see that the limbo incision by day 4 to 7 was starting to resist deformation pressure very well, where the corneal incisions were not. And then the cats were sacrificed and they were studied, and in 7 days there was no healing of the clear corneal incision, where the limbo incision was completely healed. In fact, it took over 30 days before the corneal incision healed. And the way it healed was not by an ingrowth of fibroblasts, but by having the keratinocytes undergo a metaplasia and become fibroblasts. So what does this mean for your patients? I tell people avoid swimming for 7 days. After 7 days, nothing's going to get into that eye. So now we have the geometry and we have the location, giving a pretty stable incision. And this is how it's done. I take a crescent blade upside down and create the posterior limbal incision. I dissect it into the cornea, use a keratome to enter the anterior chamber, and there's the finished product. This is what it looks like on day one. You can see my incision. One of my good friends, Richard LeCool, used a similar incision. This is what it looks like. So then the other thing I did in 92 was how does this affect the refractive outcome of the eye? And in particular, the axis of astigmatism. So we took 96 patients, 16 months follow-up. And what we found is that it had the least change in the axis of the astigmatism, which was confirmed 4 years later by Dr. Menopacci out of Austria. So Dr. Hill was a famous ophthalmologist out of Mesa, Arizona. And he had a website where you enter your data and he will actually help calculate the intraocular lens for you. So Warren and I traveled Australia together to give lectures. He did it on this, I did it on wound construction. And Red Potvin is an optometrist, actually started as a chemical engineer, became an optometrist, and is world renowned as a statistician. So the three of us collaborated on this. We wanted to look at 2.2 millimeter incisions that were square based on the limbus and corneal incisions that were 2.2. So now we're going to study the effectiveness of size. And there were 1,700 eyes in the database. We had to have at least 20 per surgeon. That got it down to 246 eyes. Vector analysis was done by Dr. Potvin to study it. And here's the results. So for the square wound, posterior limbal, mean surgically induced astigmatism was a quarter diopter. Standard deviation was about an eighth. Look at the others. At least 2 times greater in SIA and almost 3 times better, or worse rather, in standard deviation. And then when you look at a bar graph, take a look at surgeon number 2. He's got anywhere from a quarter diopter of induced astigmatism up to 1.5, and with a standard deviation of that up to 2 diopters. So explain to me how you're going to treat patient and treat astigmatism if you're creating anywhere from a quarter to 2 diopters. The patients that end up with a quarter are going to be pretty happy. Patient ends up with 1.5 to 2 diopters are not going to be so thrilled. And it's the same incision. And here's the data when we look at all the groups combined. Less than half on the SIA and a third based on standard deviation. So not only do you have difficulty in treating the amount of astigmatism, but also now you have difficulty treating the axis, because the more astigmatism you induce, the more you're going to change the axis. So here's a case study. Surgeon did surgery, excellent surgeon, did 2.2 millimeter corneal incision, targeted 80 degrees to put a toric lens. And on day 1, the lens rotated 10 degrees clockwise. Well, for every 10 degrees you're off, you lose 30% of the effectiveness of the toric lens. So he did a recalculation based on a Berndal-Harden formula, asked me to review it, and I pointed out, I said, look, your axis went counterclockwise 10 degrees. So even if that lens would have stayed at 80 degrees and not rotate clockwise, you still would have been off 10 degrees based on the shift of the axis. Okay, something's going in again. Where are you? I imagine it's had to get a chair. So yeah. It locked up. It's okay. There we go. Thank you. All right, so then why isn't everybody using this incision? And that's because it's more difficult to use. The biggest problem you have is what's called ballooning of the conjunctiva. You make a little cut in the conjunctiva, either where you make the vertical incision or you make the section into the cornea itself. And then fluid comes out during the procedure and the conj starts blowing up. And it can happen very quickly. And if you don't get out of the eye immediately and make a little pretty incision, pretty soon you have 360 degrees of balloon conjunctiva, water's accumulated on the surface of the cornea, you can't finish the case. So a lot of surgeons will avoid this incision for that fear of having ballooning. But you can avoid it. You can also stop immediately, what surgeons like to do, come out of the eye and do a little mini peritomy, which heals the next day. And fortunately, some of the newer technology, you can work through a tighter wound without causing any burn of the incision itself. So in summary, there's a statistically significant difference in lower SIA for 2.2 millimeters square posterior limbal incision. Little to no shift in the axis. And now you have a platform with which to plan treatment with. You can't plan treatment if you don't have a solid incision. So let's talk about the second laser, femtosecond laser. This was a paper that was published in February of 19 on higher order aberrations using the femtosecond laser compared to manual rhexis. All the publications up until that time showed no difference between refractive outcome, visual acuity, between femto laser assisted cataract surgery or manual cataract surgery. So a lot of surgeons said, then why use it? But what they don't know is higher order aberrations. We as ophthalmologists are not trained in that. You guys are, but we're not. If I go to a fellow ophthalmologist and say, okay, we're going to talk about Zernicke table of higher order aberrations, they think I'm talking about a restaurant somewhere that they're going to get some high-end food. And within this polynormal higher order aberration is coma. And coma basically gets its term from a comet, where you have the ball with the tail. And that's what it does to light. Not only have the point source of light, but you got a flare-like tail. So we did a study. At that time, I only had Symphony and Restore lenses. We divided them into two groups, those with the laser, those without. I did the laser. I found what I felt to be the best manual rhexis surgeon in our group and used her results for the manual rhexis. And we measured centration, angle alpha, angle kappa, internal coma, refractive outcome, and then there was a standardized questionnaire of satisfaction published in 2010. And I had a young man who's a minister give that questionnaire to all the patients from both groups. What we found was there was no difference in post-op refractive error or visual acuity, so we confirmed everything that had been published before. There was also no difference in angle alpha and angle kappa. That's a pre-op finding, not a post-op finding. So here's some numbers. On the femto laser group, whether it was Symphony or Restore, we had a very low level of internal coma. Anything 0.4 and higher is abnormal. And then on the Symphony, it was more than twice. And the p-value of that was less than 0.05, which made it statistically significant. So of the 57 eyes that had the laser, only one of them was an outlier because of a split in the anterior capsule. So what internal coma comes from is when the capsule contracts over time, say a couple of weeks to a month. You have uneven forces if it's not symmetrically overlapping the optic. And these uneven forces cause a micro tilt. Nothing that you're going to see on slit lamp, but it causes a micro tilt. And that's measured by wave scan to determine the amount of internal coma. And on the manual rhexis, 7 out of 50, or 14%, were outside the 0.4. And then I looked at some other surgeons' results, and some of them were up to 40% outside of the range of normal. Then here's an example, because not only shows this, but it's also progressive. So the upper left had 1 to 2 clock hours, and it had a coma of 0.7. Then the middle one has 3 clock hours of asymmetrical overlap. Now you're up to 1.6, and this one had 4 clock hours, and now you're up to 2.05. Here's the only femto, very nicely centered, but here's the split. And when that contracted, it still induced a coma of 0.7. Here's what you want to have. Nice symmetrical overlap with the optic, and look at the coma, 0.023. The other thing that we found is that the results were dependent on pupil size. So there is a difference between daytime and nighttime, and if you get above 5.5, then the coma becomes even more severe. So these are people that have more trouble driving at night. And here's an example. This is computer generated by Marco, and it's of a monofocal lens. Here's daytime low coma, daytime higher coma. You can see a little difference, but not anything that's overwhelming. Well, let's go to nighttime. You can see how good the low coma is compared to the higher coma. So then the next question is, does it matter? Just because we found this numerically, do patients notice the difference? So then we had this questionnaire that had 10 categories, 3 questions in each category for a total of 30 questions. Here's on the right-hand side, all the different categories. And on the left, we had them graded 0, not a problem, 1 mild, 2 moderate, 3 severe. And then they gave me the numbers. I took one look at this and I go, wow. Here we have low coma, and we have a whole variety of satisfaction here. So my first thought was, it doesn't matter. What did matter was if you had more than 0.4, nobody got into the excellent satisfaction. But so then I started calling some of these patients in after the fact and asked them to explain how they answered the questionnaire. And it turned out to be an expectation issue. One lady said, I thought the halos were going to go away. Don't know where she got that idea from. So she gave 3s in any category that had anything to do with halos or starbursts. Another one said, I thought I could read without glasses, even though it was explained thoroughly that it wouldn't be the case. So she gave 3 in every category, which is why they got up into the 30s and the 40s. So then I said to the guy who was organizing the day, I said, let's just do this. Let's take a look at the patients that had excellent scores. And let's divide it between 0 to 10, 10 to 20, 11 to 20, 21 to 30, and above 30. And let's see how they rated with regard to coma less than 0.2, which is well within the normal range. So then here's the results of that. Those that had 0 to 10, which means you had 20 zeros and at most 10 ones, which is an excellent outcome. 100% were under 0.2. In fact, they were all under 0.15. Then you went to 11 to 20, 93% were under 0.2. And then you can see it drops down to 60, and then over 30 it was 46. That p-value was less than 0.001. That is huge, statistically significant. So while expectations can give you a variety of outcomes, those that had the excellent satisfaction scores definitely was related to the amount of coma that they had. So what's the summary? There's a correlation between anterior capsule overlap on the optic and coma. The more symmetrical, the lower the coma. The laser is the one that gives you a higher level of excellence when it comes to overlap of the anterior capsule. Internal coma affects the quality of the patient's vision and their mesopic. And what's interesting is that these patients will sit in your office, they'll read 20/20 on the eye chart, they'll have minimal refractive error, and they will tell you how unhappy they are. And you're going to sit there and scratch your head and say, I don't understand why. This is one possible reason why. It's not the only reason. All right, let's talk about the Vivity lens. This is a lens that many of you in the audience and colleagues who are not here tell their patients to put money aside for. Never had in all the years I've been doing this had this kind of a reaction from your group and others. So when you have a monofocal lens, your focal point is 1. You have it basically at 1 point. If you try to bring material in, you get a blur circle and you can't read. The ideal extended depth of focus is a linear line, so no matter where you bring it, you're able to see it exactly without any problems. So it's called a channel, and you want to have as many of the light rays as you can stay within the channel, and the smaller the channel, the better the quality. Multifocals have a channel, but they also have a lot of rays outside of the channel, and those are the halos, and that's why patients complain. So wavefront shaping changes the light by stretching it, and it stays within the channel. And it gives you the same profile similar to a monofocal lens. It's called X-wave technology, where some rays are stretched, others are delayed, and you get this 1.5 diopter depth of focus without anything being outside of the channel. Now you have to make sure that the technology is properly centered, which is why I use the femtosecond laser. If it's not properly centered, you will get ghosting. Here's a picture of the lens. When you look at it from oblique, you can see the imprint. It's not rings. If you don't look at it from oblique, it looks like a monofocal lens. It's also interesting that the landing zone can be anywhere from -0.5 to +0.5. So this is where a little bit of math and art comes into play. Because now you have to really see where you want to hit this. You can't just use a constant 119.18 constant, or you're going to leave people -0.5 to -75. Some might enjoy it, but others are not going to like it at all. So you have to vary the A constant. You have to figure out what they do. You have to see whether they're hyperopic ahead of time or myopic ahead of time. You don't want to leave a myope hyperopic. You don't want to leave a hyperope myopic. All these things come into play. So there's a little bit of art to this as well as a heck of a lot of science. But you will be within 20/20 through the mid-range. And then when you get inside to about 16 inches, you're about 20/40 to 20/50. So you can still read, but you can't read small print. It's also interesting, there's no interruptions on the light. Monofocal doesn't have any, but your Symphony and Panoptics do. And then you get Vivity, it has no interruption of the light rays. And you can do a little modified Monovision and move it to -0.5, so you can go from 1.5 depth of focus to -2. And that's done on a lot of patients. So then they did profiles, see how well you could see compared to a basic lens. Distance was the same, intermediate was much better, and near was much better, whether it's during photopic or mesopic conditions. Visual disturbances was the same as a monofocal lens, less than 2%, any halos or starbursts. Same for a monofocal lens. So, Mr. Dorn's here, Vice President of Alcon. Where are you sitting, Bill? Over here. So Bill called and had the project director and the man who invented this lens. They wanted to run it by me. My first reaction was, who in the heck would ever want to buy this lens? Because you can't read. Bill reminds me of this all the time, so I thought I'd get out in front of him and just put it on a slide and admit that I was wrong. Currently, Vivity accounts for at least 60% of all my surgeries. It outpaces multifocal lenses 200 to 1. It even outpaces monofocal lenses up to 3 to 1. This lens is the most accepted lens by patients and referring doctors I've ever had the pleasure of using. What it gives you is a natural depth of focus similar to a 45-year-old. Now, I tell all patients I can't make the rest of the body 45, or I'm going to jump ahead of you and get mine done first, but I can get your eyes back to 45. So think of that, being 45 for the rest of your life. You just need some 1.25 or 1.5 readers inside 20 inches. But what's really nice about this lens is you can vary the focal point of this lens. You can't do that with other lenses. And I'll explain this in a little bit. So Vivity is basically a monofocal lens with extended depth of focus. You can use it on anybody with some exceptions. People with poor visual prognosis like severe macular degeneration or ischemic optic neuropathy, you're not going to put a Vivity lens in that person's eye. It's not going to do them any harm, but it's not worth the money to put it in. People with diplopia requiring prisms. Again, if you have to wear glasses with prism, why do it? And then high corneal coma. So everybody with LASIK, RK, or has inherent corneal disease, you have to look at the corneal coma, because if it's distorted, then the lens is going to work. But you can use this lens in moderate dry eye, diffuse corneal endothelial dystrophy, many patients with that, epiretinal membranes with good vision potential, LASIK with low corneal coma, RK with reasonable topography and low corneal coma, minimal field defects, recent macular hold is scheduled for surgery repair with favorable outcome, stable ARMD with good visual prognosis, and especially your OCD patients where little things bother them a lot. You're surely not going to put a multifocal lens in somebody that walks in with 1+ cataracts and is dying because of the glare they have at night. You're asking for trouble if you do that. And you're not going to think much of the surgeon if we do that. Let's talk about monovision. I've always had passion for this subject. In monovision, you have all the energy going into one bucket for distance and all the energy in the other eye going to the near bucket, and the middle bucket is left out. And when I've gone through patients' lifestyle, the middle bucket is where everybody spends the majority of their time. So I tried to find ways years ago how to get energy from the distance bucket or the near bucket into the middle. So I came up with a multifocal lens. And I put it in the distance eye that would move some of the energy to the middle. And I said, good, this is going to work. Didn't work. I quit that very soon. And the reason why it didn't work is patients do not like to give up something in order to get something. So the fact they gave up some quality of the distance or quality of the near in order to get the middle was a non-starter to them. So I had to quit it. So let's put the Vivity in the distance eye. Now we're stretching the light. We haven't taken any energy away from the distance bucket at all. And we now give it all the way down to a depth of focus of 1.5, the low middle bucket. So now patients are absolutely thrilled. I honestly believe every monovision patient should have Vivity in the distance eye, without a doubt. If you're not getting your patients with Vivity in the distance eye, I think you're doing them a disservice. That's a very strong statement. I'll stand behind that. Because now the patients are getting something extra that they didn't have before. So what about the near eye? I have 7 of your colleagues with this, and 2 of them have monovision. So you can set it from -1 to -1.25. Now you're getting the depth of focus 2.5, 275. So now both eyes have middle. One has more distance, one has more near. They never wear glasses again. And if the patient can't afford 2 Vivities, well then fine. We'll put a monofocal lens in the near eye and set to -2. So you got distance middle on the one eye, you've got -2 near on the other for half the price. That works fine too. You can even do this if you're setting both eyes for distance. I tell patients that 2 Vivities is better than 1, but 1 Vivity is better than 0. So, and if I do that, it's not in my slides, I will put the Vivity in the dominant eye and then just put a monofocal lens for distance in the non-dominant. So you don't have to say, if you're not getting 2, you can't get it at all. That's not true. And it works very well. Dr. Tom Cunningham, I'm sure most of you know him. He wanted monovision and he wanted the near eye to be very close so you can see the 4-opter and all the numbers on the 4-opter when he did his refraction. So we actually aimed for -2 and we nailed it. He's 2015 on each of these categories. And Tom put this out. Still waiting for my hug, Tom. But anyhow, he was very happy. And then he did a video for the practice, which I was unaware of that he did. And I'm going to have you bring it on up.
Ready for me to play?
Yep.
My name is Dr. Tom Cunningham. I'm an optometrist, eye care specialist in Tecumseh, Michigan, and Saline is where I practice. And my typical day, I start by looking at my schedule, and we run the patients through their preliminary workup. And then they come back to visit me into the exam room, and I go to work trying to take care of their visual needs. If I can help them, we fit them with eyeglasses, contact lenses, we check for diabetes, we check for glaucoma, and many other eye conditions that can happen. It's imperative to have good vision as an optometrist because you have to relate to patients, you have to fit them with glasses. It's just very important with your everyday activity to have good vision. I've always had vision issues ever since I was in approximately 6th grade. I was nearsighted, and as I got older and got into college and then into optometry school, I found out about contact lenses. And contact lenses were wonderful for my type of activity. Yeah, what happened was a typical situation with a patient. They'll come in 1 year, and you've been seeing patients for years. You'll notice a slight decrease in their vision, but you can correct them with glasses, and you notice that their lens in their eye is changing. Okay, the lens of the eye is internal, and it changes color. It gets more yellow, more foggy as you get older. And I was having this continual change too with my prescription. Yes, I could see 20/20, but 20/20 is not the end all be all. There's 20/20 good vision, 20/20 bad quality vision. Plus, I was seeing many blue and yellow halos around lights at night. And I knew that was something that I had to address. And that's when I said, it's time for cataract surgery. I chose Specialty Eye Institute because I've worked with them for many, many years. I've worked with all the doctors there, and I think they're very excellent surgeons. And they've all been very receptive to try to help me in my quest to give my patients the best care possible. And when I cannot do it myself with my vision specialties and my skills, I have to send them on. Me being a vision specialist, I thought there's so many choices. Okay, first of all, I did not like the concept of a bifocal implant because I didn't have luck with the bifocal contact lenses. And I did not want any glare. I did not want to have to determine between two different alternate areas to read. And I thought, okay, I'm going to talk to Dr. Ernest about monovision, where you get the dominant eye perfect at distance and then the other eye for reading without having to wear contact lenses. Dr. Ernest mentioned to me that, Tom, there's a new lens out, and it's been out for approximately 2 to 3 months. He said, very successful. And people are not talking about glare from this lens, visual side effects, and they're reading very well. And I said, wow, that sounds pretty good. So we decided to come up with an alternative to get perfect distance vision with computer distance for my right eye, my dominant eye, and for my left eye, we decided to leave me just a tiny bit nearsighted so I could get my paperwork done all the way into 10 inches. Because in the exam room, I work in dim light conditions, and I needed that. We decided that that was the best system for me. Dr. Ernest said, let's get in time. Let's do this. We did it. We did it very quickly. I was in there within a week. Had one eye done 1 week, the other eye done the next week. After my procedure, it was amazing. I thought, my goodness, I can't believe what I've been missing. Colors were bright. Whites were whites. You could see up close right off the bat. I mean, I took the day off, the next day off, went right back to work. Okay. That first week was a little tough with one eye doing the work. And I said, my goodness, I'm reading after 2 days. It was absolutely amazing. I have a lot of patients that are hesitant, worried about cataract surgery. These are all the complications I can have. If they're having any of the issues that I had over the poor quality of vision, they don't see like they used to, I'm really going to try to make them feel at ease to get this done sooner. These doctors have so much experience. They've done so many people, and you shouldn't have any hesitation to see these doctors that are so well qualified. I mean, I put my vision in their hands. I'm just very grateful that Dr. Ernest was in this area and that he really keeps up with all these innovations. It's been just a life-changing experience for me. I can't say enough about how much good quality of vision I have.
That says more than anything I stand up here and tell you personally. I want to thank Tom for doing that for the practice. He wanted 10 inches. As the slide showed, I got him to 9, so he got 1 inch more he was asking for. Let's talk about something that this is my coin phrase called Vivity in reverse. Let's take that channel and move it forward, leaving the patient myopic. What does that do? And who would qualify for this? So it's great for low to moderate myopes who like to go for the bulk of their day with no glasses. They don't do much outdoors. Maybe do a little gardening and do some driving, but they're not athletic. They're not shooting guns. They're reading more. They're doing household chores. So instead of having Vivity do distance, middle, and functional near, let's just move the whole thing and make it near, middle, and functional distance. They may be able to see their TV set, depending on how large the TV is, but they definitely are going to need glasses for driving a car. So I can't tell you how many dozens of people I have with this, and they are happy. So again, you got to do a really careful screening on the front end to see who would qualify for this Vivity in reverse. And here's one of the classic patients. He was a little more myopic than the moderate, but she basically did everything middle to near, only walking her dog. So we targeted -1 and we hit it. And now she's thrilled. She can do everything she wants to do and wear some glasses for driving in the visor of her car. So then I had a young man who was 38, still had accommodation, had no cataract in his left eye. It's naturally a -3, and had this horrific cataract in his right eye with -7. So I put Vivity in the cataract eye and targeted -2 to 2.5, so the two eyes work together. And he has depth of focus in the phakic eye, and now has depth of focus in the pseudophakic eye, and wears glasses for his distance. Now I have 3 patients. One I just did recently, they have ESO deviations, and they see double, but only at distance. So believe it or not, I had to go back and practice my skills in cross-cover tests. I want you to know that was a lot of fun. And tried to see how they were in middle to near, and they had to question them, and I don't see double, Dr. Ernest, when I look at the middle and the near. I only see double when I go distance. Well, how are you going to treat these? If you put a prism in the glasses for all 3 areas, you're going to solve the distance, but make the middle and the near worse. There is apparently a process where you can put them in trifocals and put the prism in the upper part and not in the middle and the near. That's expensive. Or you could do Vivity in reverse. Set them for -1. So now they can read it with no double vision for middle and near, see their computer, and then they put on their distance glasses with the prism, and that solves the ESO deviation. As I said, I have just completed the 3rd patient with this. All of them have done well. So how about some other uses of Vivity? Well, here's a patient with 4 RK. Kevin, I think you did a great job. And she ended up hyperopic, which a lot of RKs do. And she had some astigmatism, especially in the left eye, in the right eye, I'm sorry. And we did Vivity toric in the right, Vivity in the left, and that's how she ended up. But she also had very good topography results and very low corneal coma. If she didn't have this, you would not get a good result with any lens other than monofocal. So what about multifocals? Are they dead? No. Put a Panoptix in yesterday. The 2 current ones are both Panoptix and Synergy. I will, when someone comes in with multifocal contact lenses and they like it, and they tell me they don't have to wear supplemental readers up close with their multifocal, which is a question you need to ask, I'll consider it. But they've already adapted to the halos. So you got to kind of match what they're used to. And unfortunately, Vivity only comes in certain power ranges. It doesn't take care of some of the high myopes or some of the extremely high hyperopes. So again, if they don't want to get monofocal lenses, then the multifocal is your next choice. How about mix and match? My first 2 patients were optometrists. How was that for taking on quite a challenge? First one's from Columbus, Ohio. The second one's from Owasso, Michigan. So the guy comes in from Columbus, Ohio, and he likes to be able to read without glasses. It's a myope. So what we did was we put Vivity in the non-dominant eye, and I put Panoptix in the dominant eye. It's very important that you put the Panoptix in the dominant eye. Because if you put it in the non-dominant eye for fear of the halos, then you're not giving the brain what it's looking for, which is the ability to read without glasses. So I did it. Very tentative. Great guy. And Rod called me back, told me how much he liked it. What he told me was, he said he got the near vision in the dominant eye that he was looking for. He loved the depth of focus in the non-dominant eye, and he only got half the halos, and he really felt that the lens complemented. So then the next optometrist I took care of was out of Owasso, who was naturally a -3. And we talked, and we put Vivity in the non-dominant eye, see if he liked it. He said, well, I love it, except I can't read. So I had him call his colleague in Columbus, Ohio, and they talked, and we decided to put a Panoptix in the dominant eye, and he loved it. Well, if I have 2 optometrists that like it, I guess I could take on the rest of the world. So I have at least 6 patients with this combination. I have 3 more on the books, and they really do complement her. It's not my first go-to step, but on certain people, it definitely works. So you can consider that for your patients. So if you're going to use any of these lenses, Vivity or multifocal, you have to control the astigmatism. So this is my plan. People have asked this question. I will treat astigmatism with the rule at 70 to 110 degrees on a positive sill, up to 1.5 diopters. If you got more than that, or if you have oblique sill or against the rule sill, I'm going to go to a toric version of the lens. I've done the nomograms, published it in 2013. You don't get good outcomes if you're treating cylinder obliquely. It ends up against the rule with the laser. And you don't get good results if you treat over 1 diopter against the rule. And you don't even get good results if you try to go above 1.5. So the 3 legs to a consistently successful cataract surgery. I understand where the title came from. Is first of all, the posterior limbal square incision gives you mechanical stability, low SIA, rapid healing, and most importantly, minimal change in the axis of astigmatism, allowing for more precise treatment. The femtosecond laser gives you precise centration, symmetric overlap in the anterior capsule, reducing high order aberration. And the Vivity lens gives you this natural depth of focus similar to a 45-year-old, no halos or dysphotopsias, and you can change the focal point to match the patient's lifestyle. I want to basically just end the talk with this. I really appreciate the support, as do my partners, for all of you. We are a referral practice, not here to compete against you. So this is my customer relation mission statement. The customer of the surgeon is you. Your customer is the patient. Our job as surgeons is to take the best care of your customer to help maintain our professional relationship. I feel very, very strongly about that. So thank you, and I'm open for any questions that anybody may have. Yes.
So some of the coma is coming from the capsule on these patients. Does a gag help them?
I'm sorry.
So if some of the coma is coming from the capsule being stretched or tipped.
No, it's an uneven overlap. So yank is going to do anything for you. In fact, if you open the anterior capsule like I had inadvertently on that one patient, you actually increase the internal coma. Other questions? Either I answered everything or totally confused everybody. No question? Is it too early? Come on, there's got to be a question. Jamie, ask me a question.
Paul, is there anybody who won't put a Vivity lens?
Yes, I won't put a Vivity lens in people with bad macular disease, bad optic nerve, bad corneal coma, and those who need prism in their glasses. And obviously those who can't afford it. But otherwise, it's wide open. Yes.
Going with patients like those of us that have had PRK, I know you did the one RK, but LASIK, PRK, I mean, how concerned, you're a giant in this field, how are we gonna do with some of these younger people that don't have the experience?
Well, our job is to educate. You really have to look at the corneal coma as Tony was bringing up. Yesterday, 4 of my surgeries were LASIK patients. And more of the LASIK patients are now coming for cataracts. Not everybody can get it. Because if you end up with multiple choices I use 2 different formulas to calculate the replacement lens. And if I have 4 lenses to choose from, it's anywhere from a 20 to a 21.5, I'm not going to put a board and throw a dart at it and hope I get the right one. That doesn't work that way. So if the numbers are tight on the calculations and the corneal coma is low, if I look at it, then it's a go. So unfortunately, most of you don't have access to the machine that will test it. So it's important that the surgeon do that. Okay? So you can't promise them they're going to get it, but you can promise them we're going to at least consider it.
Down the road.
Well, you just come on in And we'll take a look at you, and I'll tell you, I mean, my sister-in-law heard a lecture I gave and immediately makes an appointment. And she had LASIK by me, but she had too many choices on the lens power. So I said, Jane, I'm not going to guess. You're not a candidate. So that's how I left. Other questions? Yes.
With the multi, focal dominant, are you trying to just pick up everything?
Yes. Well, good question. If you come in with monovision, I'm going to leave you monovision. I will not change that. If you don't come in with monovision and you want to try monovision, I'm going to send them back to you and have you do a trial of contact lenses to make sure they like it for a period of time before we go any further. That's assuming the cataract's not so terrible that, you can't assess that. But if you come in and you just have the strong desire to read, especially if you're a myope, then this will be an option. Obviously, for the thousands and thousands I do, they have only 6 people, 2 of which are your colleagues, having this mix and match. It's not my go-to combination. I'd much rather vary the focal point of the Vivity lens to get you what you need, of course.
Great, thank you.
You're welcome. Now we've got people start to ask questions. Yes.
Are you requiring the femtosecond laser for all multifocals and Vivities?
Me? Yes. Because of coma. I mean, you have halos with multifocal lenses. How would you like to have flare on top of the halos? What you saw in that one picture, focal lens. See how much flare you had on that? Think of how unhappy that patient's going to be.
So for people that refer to Lansing area for cataract surgeries, that they would be required to come down to Jackson to have a multifocal implant?
I don't tell other surgeons how to practice medicine. You ask me what I would do, that's what I would do, and that's the reason why. It's their choice. Remember, the one partner had 86%, very good outcome. You play golf with me. 86% is not good enough. Okay? That's just the way I'm wired. Any other questions? Come on, David. That other. My swing, my lack of distance, and the fact I don't have any time because I'm working too hard to practice. Michael, how are you?
Oh, when you get, I'm a patient with a multifocal posterior capsular presentation. I used to, back before I said it, I said some of the silliest PCOs now. But yeah, sometimes I'm questioning that.
The amount of PCO is not as important as the location of the PCO. If it's more central, small amounts going to cause more problems. If it's more peripheral, it may not. It also depends what the complaints are. If they're complaining about halos, you're not going to make it any better by doing the egg. I think I saw another hand somewhere. Another question. Yes. I can't hear. I'm sorry.
Roughly, what's the pocket on this?
That's a good question. When I answer that question, I like to answer what other people in the state charge. Detroit area is about 4,000 an eye for lens and laser defined. And we're at 2550 an eye. So we have been fortunate that our parent company has allowed us to maintain a very low financial profile to meet the needs of patients in rural Michigan. Any other questions? Okay. Oh, yes.
Kind of a question comment from experience. I found out light is extremely important. Is that true even for monofocal cataract surgeries where they end up with a monofocal lens?
What do you mean? The intensity of the light?
Yeah, and of course, then I'm comparing it to reading. I just found out that I definitely have to have bright light to read for that panoptics.
Yes.
would that have been true with a, Vivity monofocal or a monovision setup? Is light still gonna be quite a big factor?
Not as much. The reason Panoptics is because only 25% of the light energy is going to the near vision. So that's also why early retinal changes, both before and after the surgery, come into play. 50% of Panoptics, 50% of light energy goes to your distance, 25 middle, 25 near. So that's what you're noticing, okay? Where Vivity, by stretching the light, you're not compromising the amount. And then you could move. And plus, you're going to wear readers for inside 20 inches.
Right, which is obviously one of the topics of trying to avoid needing reading glasses. And
Then you move them on down to a half diopter, 3/4 diopter.
Right.
Towards myopia, so you don't. There's no cookbook approach to this,
no,
which also makes it fun. But it's a lot of time to sit there and do this. I can't delegate this to one of my staff. I just feel I need to sit there and have this conversation with each and every patient. Any other? Yes.
Are there any plans to go back to injecting the steroid and the antibiotic during surgery so the patients don't have drops afterwards?
Well, actually, it's a good question. And you could get all sorts of debates on that. So the reason why I don't do it is because you do have an incidence of CME. It could be as high as 5–10%. I do over 2,000 surgeries a year. That means I'd have between 100 and 200 patient eyes with CME. I just don't want that. There have been reported incidents of TAS. Problem with drops is surface issues. You know, makes the surface more rough, makes it harder for them to recover. We finally, thanks to Dr. Lavery, are going to have it all in one drop. So starting when, Kevin? Okay. So now you've got everything in one, so at least and it's cheaper, it's compound made. So that helps. So I didn't really answer your question. That's really debatable. It's nice when it works. It isn't when it doesn't. Any other questions? Yes.
I just missed, when did they say that the compound pressure is coming?
Yes, the compound drop currently is out.
Okay.
I mean, within the last 2 days, I think start using it. Hopefully next week I will. What agents are? What's that? What agents are? We have moxifloxacin for the antibiotic, Romfinat for the non-steroidal, and prednisone acetate. And then what's that?
The price too. It's like,
Yeah, it's like $25 a bottle. Okay, and then there's two different types. Some have it without the antibiotics, some have all three. Some of us, including me, are going to use the antibiotic part for 1 week, go to the non-antibiotic for the rest of the time. Others will just use all. That's the student side.
Yeah, I'd like to go back to this, the YAG question. I realize Vivity does not have refractive optics, but Optics does. Would you say that it's much more sensitive to posterior capsule calcification to refractive optics?
I would say yes, only because you're dividing it. I should have. But again, it's also where it's located.
Yeah.
Yeah. Any other questions? Yes.
You're gonna be doing, pure lens extraction.
Oh, already out. Tons. And it used to be predominantly Panoptics. I know Bill likes to hear me say this, but now it's predominantly Vivity. Okay, thank you very much.